Good afternoon. First of all, I'd like to thank the organizing committee and Malaysian Orthopedic Association for inviting me to this very important meeting. On this occasion, I will talk on ACL graft selections. As we know, ACL reconstruction is a very common operations in orthopedic surgery. There are around 100,000 operations a year in the US alone. The midterm failure rate is around 5 to 10%, and the long-term failure rates is around 12%, and many factors affecting the result of ACL reconstructions. Some important factors are graft selections, panel positionings, graft fixations, and rehabilitations. And graft selection is probably one of the most critical issues. And the patient choice for ACL graft selections primarily will depend on the surgeon's recommendations. The ideal grafts should be reproduce native anatomy and normal biomechanics. It is easily harvested, low donor site morbidity, and rapidly incorporated with bone, with strong initial fixation and limit risk of disease transmissions. Unfortunately, till date, there is no ideal graft. And if you look at the biomechanical properties of the ACL grafts, all commonly used grafts have higher strength and stiffness compared to native ACL. What about the selection of ACL graft selections? In the past, bone patellar bone was considered as the gold standard for graft choice, but this is rapidly changing. With the evolution of cell graft technique, improvement in technology, there are more variability in graft choices. So it is very important for the surgeons to understand the advantages and disadvantages of each graft. A very interesting epidemiological study from CHER6 involving surgeons from many parts of the world show that hamstring is the most popular graft used for ACL reconstruction today compared to BPTB and allograft. The graft option for ACL could be autograft, allograft, or synthetic graft. For the autograft, the commonly used grafts are bone patellar bone, the hamstring graft, semitendinosus with or without gracilis tendon, quadriceps tendon, and recently the peroneus longus tendon become more popular. We start with BPTB. The advantages of BPTB are high strength and stiffness. It has a vaster graft incorporation because it's have bone with bone and bone healing, a consistency in size, and excellent fixations. But the disadvantages are donor site morbidity, like anterior knee pain, kneeling pain, and extensor strength deficits. Patellar fracture and patellar tendon rupture could also happen, and it needs larger incisions. What about hamstrings? Hamstring have advantages of quick harvesting. It has lower donor site morbidity than BPTB. It needs smaller incisions. It also has a stronger tensile strength and can be used for double bundle reconstructions. And there are some studies showing that there are hamstring regrowth after harvesting the hamstring tendons. The disadvantages are knee flexor strength deficits. It is greater if gracilis is also harvested. Graft size not predictable. It is soft tissue to bone healing, so it's longer than BPTB and less fixation strength. There are a lot of studies comparing BPTB and hamstring graft in many different aspects. In failure rate, a systematic review from Monahan showed no difference in long-term outcome in failure and laxity between the BPTB and hamstring tendon. Other studies show that hamstring graft has a higher failure rate, but the failure rate in each group actually is very low. Regarding the muscle strength affected, in BPTB graft, there is greater deficit in extensor muscles and lower deficit in flexor muscles compared to hamstring graft. The deficit muscle strength in hamstring also depend on number of tendon that harvested, so preserve the gracilis where possible. If we compare the stability between the BPTB and hamstring graft, several meta-analyses and systematic reviews show that no difference in anterior laxity by Lachman test and KT 1000s in both grafts. The patient with ACL reconstruction has a risk of developing osteoarthritis, and graft selection is one of the factors associated with OR. There are studies showing that using the BPTB graft resulted in increased incidence of both patellofemoral and tibiofemoral osteoarthritis, although there are also studies showing that graft selection is not a significant predictor for osteoarthritis. What about the pain? The BPTB grafts have a significantly higher occurrence of anterior knee pain and kneeling pain than hamstring tendon. So BPTB graft should be avoided in patients who have strict requirement for kneeling, such as for employment or for praying. And in countries like Indonesia or maybe Malaysia, where many people need to pray and kneeling 5 times a day, kneeling pain will be very devastating. That's why we rarely use BPTB as a graft options. The other thing is the tunnel enlargements. It is more common in hamstring graft, but it doesn't correlate with clinical outcome. When using hamstring graft, so the femoral tunnel placement should be created slightly posterior, since tunnel enlargement usually anchors anteriorly, so it will reduce the risk of decreased joint stability. The other graft is quadriceps tendon. The advantages of quad tendon are: it's a strong graft, it's comparable with BPTB, is less donor site morbidity compared to BPTB in regard to anterior knee pain and kneeling pain. It has a bone block in one end, so it's low bone-to-bone healing. The disadvantages are the quadricep muscle weakness and anterior knee pain. The other graft is peroneus longus tendon. It becoming more popular recently in many Asian countries. It's a big graft. Our studies showed it has a comparable tensile strength with hamstring graft. There are also several studies showing promising results as an alternative graft for ACL reconstructions. And also it has a minimal donor site morbidity. The advantages of peroneus longus are as a big graft, easily harvested, less thigh hypertrophy than hamstring tendon. It can be used for double bundle and it has comparable mechanical property with hamstring tendon. The disadvantages of peroneus longus tendon is possible lunoside mobility, although some studies, including our study, show that there are no difference in ankle functions with the contralateral sides. The other ACL graft option are allograft. The commonly used allograft are BPTB graft, hamstring tendons, tibialis anterior posterior tendon, dan Achilles tendon graft. The advantages of allograft: no donor site mobility. We have a predictable graft size, shorter operating time. It needs smaller incision and is of use in multiple ligament or revision cases. But the disadvantages are risk for disease transmissions, slower incorporations, higher risk of revision in younger and active patients, and the sterilization process might affect mechanical property and of course cost and availability. Like in Indonesia and many parts of the world, allograft is hardly available. The other option are synthetic graft. The earlier generation of synthetic graft like Dacron, Gore-Tex, Leeds Kayu show high risk of complications including recurrent pain, mechanical failure, infections, tunnel osteolysis, massive effusion, and osteoarthritis. Newer generation like Lars has been reported to have lower failure rates. But the result of is quite conflicting comparing the synthetic and autograft. Penn reported that the result of RAS and BPTB with 4 years follow-up is comparable. Liu also showed that no significant difference between Lars and hamstring grafts. But the different book showed that high failure rate of Lars in long-term follow-up with 50% re-rupture rate. So they don't recommend synthetic graft as a graft option for ACL. Chen in 2019 showed that the synthetic graft has a failure rate of only 4.5% in 7 years follow-up, which is comparable or even better than autograft. So actually, it needs more large cohort study to justify the use of synthetic graft. So based on the literature and based on what we have discussed in the previous slides, so my graft of choice are first is hamstring grafts, semi-tenuous only if possible. The second is peroneus longus autograft. The third is bone patellar tendon bone autograft, and the last is quadriceps tendon autograft. We don't have allograft in our country, so we never use it. We also don't have experience with the synthetic graft. In conclusion, the ideal graft is not available yet. Choose the graft that matches the patient need. Graft selections is affected by many factors such as failure rate, gender, age, level and type of activity, complications, and surgeon familiarity. So discuss the advantages and disadvantages of each graft with the patients. And peroneus longus tendon is promising graft for ACL reconstructions. Thank you.